Hello, welcome everybody. Welcome to Disability Innovation Live. I can see that we're getting lots of you joining from all over the world, so it's fantastic to have you here. In the session today, we're going to be looking at the country capacity assessments, and these are really about looking at supporting country governments to address AT access. So just a little bit of information before we start today's session. There is closed caption and BSL available. So to turn on your closed caption, there'll be an option. It's normally at the bottom of the screen. And in order to view BSL, you just have to turn your gallery view on. So if you look at the top of your screen, there's normally a green bar. And next to that green bar, there's an option to click where you can view options for a menu. And if you click the view side by side, that will give you the opportunity to see both the speaker, but also the BSL at the time as well. But just to make a note that that's only available for desktop users. Through the session, we'll really like to have your questions come in, and we'll be doing a Q&A at the end of the session. So please do put those questions in the Q&A box, and we will be responding to them through the session, but also at the end as well. And this session will be recorded and there'll be a transcript available. We will make those available within about a week and send them to you. So Disability Innovation Live. So Disability Innovation Live is run by the Global Disability Innovation Hub, and it's really an opportunity for us to share some knowledge and expertise and experience in disability innovation, not just from us, but also our global partners and friends around the world of disability innovation. And we really look at the stories behind the innovations and the people behind the products. So it's a bit of an informal space to share ideas and reflections, but also to get some feedback from you all and hear about the different work that you're doing globally in the area. So just a little bit about the Global Disability Innovation Hub. We are a research and practice centre driving disability innovation for a fairer world. We were born out of the London 2012 Paralympic legacy, and we are both a community interest company and also a research centre at UCL. We are currently working in 33 countries, and we're looking to reach 15 million people by 2022. So we've got a brilliant panel of global experts joining us today. We have Vicky, who's the CEO and founder of the GDI Hub. We've got Emma and Maria from the WHO, who I'll leave to introduce themselves in a little bit more detail when they do their presentations. And we've also got Maggie and Estu from CHAI, and we have joining them Mr. Abbas. And we're also going to be here from Julian from the Development Planning Unit at UCL as well. So I'll leave all the speakers to just go into a little bit more detail and introduce themselves during their individual sessions. So I'll first of all hand across to Vicky just to tell us a little bit more about some of our work in this area and about the country capacity assessments.
Thanks very much, Louise, and welcome everyone. It's great to see colleagues from all of the different organisations that we've worked with on this project. And I also know we've got Luke Postain, who did the research for us, Luke lurking in the audience too. So thanks very much for joining us. For those of you that don't know, and if you're a follower of Disability Innovation Live, you probably do by now, AT 2030 is our flagship programme on assistive technology. We know that we need to address the huge global need to access assistive technology, which Emma will tell you more about. And AT 2030 is here to test what works in improving access to life-changing assistive technology. It's here to take risks, sometimes to fail, and often to find new ways of doing things that help us address this need. It's a £20 million investment by UK aid over 5 years, which we at GDI and with our partners are match funding. So it's a £40 million project, and we will reach 9 million people directly and 6 million people indirectly. We've already reached around 4 million people, so we're doing well so far, but there's a long way to go. It's focused on testing community, system and innovation-led drivers for change. And this project, developing tools for governments mainly to address access to assistive technology, is very much in the system support space. And so the country capacity assessments have been developed from an original WHO tool. They've been enhanced in terms of usability, user engagement and refined data with lots of input from the CHAI team, as you'll hear. And their aim is to aid decision makers to make better planning decisions for AT provision in countries, along with gathering additional supplementary information, and they go alongside a suite of other tools, including the RATA, which I'm sure Emma will mention. We've trialled this tool in 7 countries in Africa, as well as Mongolia and Indonesia, and work is currently ongoing in Vietnam, Bolivia and Dominican Republic. And our aim is that now the tool has been tested in countries, as Emma will tell you, it will be available for other countries to use, and it should improve access to assistive technology around the world. So without further ado, I'm looking forward to hearing from our speakers, and thanks again to our funder.
Fantastic, thank you, Vicky. So just before we begin and hand across to hear some more from the World Health Organization, from Emma and Maria, about their involvement and I guess the wider implications of the project, we just wanted to ask everybody kind of what country they're connecting from. So if you're joining us as an audience member, please do pop in the chat box or the Q&A whereabouts you're joining us from. We know we've had people register from, amazingly, 70 countries around the world. So it'd be brilliant to hear a little bit about where you are, just so that then we can talk maybe a little bit more specifically about your areas as well. So at that point, I will hand across to Emma, who's going to introduce herself and tell you a little bit more about the WHO and their involvement.
Thanks, Louise. Hi, everybody. It's a real pleasure to be here today and finally reach this milestone where we're launching our tools and telling you about the work so far. I work in the WHO Assistive Technology team in Geneva, and I'm based there. So I want to kick off by just talking about why are these CCAs important. And on this slide, you can see a graphic highlighting that only 1 in 10 people have access to the AT they need. So a statistic we're all very familiar with. And I think there are 3 key barriers to access which the CCAs particularly address. And those are low awareness, lack of prioritization by governments, and fragmentation. And that fragmentation is across stakeholders, policy, services, supply, across the board. Thanks, Louise. The main tool, as Vicky said, to collect the data for the CCAs was the WHO's new Assistive Technology Capacity Assessment Tool, or ATA-C. And the tool was really developed and refined through the experience of all these country capacity assessments. Vicky mentioned the countries that were funded through the AT 2030 programme, and there were also some additional assessments led by WHO in Iraq and Bahrain, and Tajikistan, which informed the development. And we've worked in collaboration with CHAI, who have really played a core role in developing the tool and the process. Sorry, please, to the last one. So this slide gives a brief overview of the areas covered by the tool. So it looks at existing policy on AT and relevant financing schemes, product availability, quality assurance mechanisms, procurement and supply processes, existing AT services, workforce, and any relevant education and training in the country. And then understanding the experience of people, the people who need AT in accessing those systems and services, as well as understanding the need in the population by using existing data if there's no capacity to do a specific activity on data collection. So we're really pleased to be launching a portal today where the tool and supporting documents can be accessed. The portal is going to be managed by WHO so that we can play a role in facilitating coordination in countries, and also will be a platform to share learning and for discussion and support. And so the ATA-C is one of 3 tools in a new WHO toolkit. And this slide shows a graphic of those 3 tools. So in addition to the ATA-C, we also have the RATA, or Rapid Assistive Technology Assessment Tool, which is a household survey to collect data on need and unmet need in the population. And Julian used that, and we'll talk about that in a moment. And WHO will be publishing a paper version of that tool shortly. And then lastly, the ATA Impact, which is in development and will be available at the end of next year. and will be a short set of questions to measure impact of AT for any type of AT user with any type of product across a number of areas such as inclusion and participation, and that's still being scoped at the moment. So I'd like to hand over to Maria, who is going to talk about Bolivia a little bit and how they're already discovering how the process of implementing ATAC is addressing fragmentation and raising awareness.
Thank you, Emma. And thank you, GDI Hub, for the opportunity to share our ongoing experience with the ATAC implementation in Bolivia. But before I share this brief experience, we would like to learn a little bit more about you. So we are going to launch a poll right now with the question, what is the focus of your work or interest in assistive technology? And we ask you to select as many as you like from vision, hearing, mobility, communication, cognition, and self-care. So please share a little bit more about yourselves.
And just as we give everybody a minute or two to add in their interests, I thought I'd just do a little summary of some of the areas that you're joining from today, which is incredible to see. So I can see we've got people from Liberia and Israel, the US, India, Switzerland, Malaysia, France, Melbourne, Zimbabwe, Thailand, and many more coming through as well. So it's absolutely fantastic to have so many of you join from all over the world and have such a vast array of expertise as well.
Thank you. Can you share the poll results with all of us, Luis, please?
Absolutely. So you should be able to see them on your screen now.
Yes. So we have the majority of the people that are connected today are interested and have experience on mobility, followed by communication, then cognition and vision, and then self-care. And we didn't receive any responses related to experience with hearing. So thank you, everyone. It is great to see the diversity of the group. So can we go to the next slide, please? Okay. So Bolivia, a country in South America, is currently implemented the ATAC. Our implementation team is comprised by professionals from the disability unit at the Ministry of Health, with technical assistance from the Pan American Health Organization and also the World Health Organization. It is important to know that this assessment has been done mostly virtually as a consequence of the current global pandemic. Next slide, please. So during the ATAC, the first phase is the planning phase. In this phase, what we do is to conduct a stakeholder mapping, followed by the interviews with those stakeholders that we identify. In our experience in Bolivia, the immediate reaction to the stakeholders mapping was that the main stakeholders in the country were those related only to mobility and self-care assistive products, and from the programs related to the Ministry of Health, specifically to the disability unit, which are rehab centers, and of course they have therapists associated with their programs. So the slide shows the mobility and self-care products in a circle surrounded by the disability unit, the rehab centers, and the therapists around it. Can we go to the next slide, please? So with the use of the ATAC, the implementation team has been able to reflect on the national assistive technology landscape by identifying key public and private stakeholders and also individual key leaders that are enabling us to understand what is the current capacity in the country to be able to regulate, finance, procure, and provide assistive technology. So what we're seeing in the slide right now is that as a result of using the ATAC, now we are seeing a new circle intersected with what I just mentioned before about mobility and self-care. And now we're seeing and analyzing additional stakeholders related to vision, hearing, cognition, and communication. And these are surrounded by additional stakeholders that the ones that I mentioned before. So now we are identifying important stakeholders outside of the Ministry of Health, but within other ministries. and also identifying other professionals that are outside of the traditional rehabilitation professions. And of course, we are engaging with users of assistive technology and organizations of persons with disabilities. So in the slide, we see that there are a lot of bubbles that intersect, and the purpose of depicting it in this way is that we currently are identifying coordination and collaboration, and also identifying potential opportunities for collaboration and coordination. So with this very brief story, can you go back, please? With this very brief story about Bolivia, we just want to share that only with the planning stage of the ATAC, we have been able to identify two key things. First, we have been able to increase the awareness with the implementation team that assistive technology involves many things, including policy, financing, products, and their procurement, and also provision, and of course the personnel, but that it responds to the need that the country has. And second, it has become evident in these first implementation phases that there is a significant fragmentation in the country for the assistive technology sector. And we also wanted to share with you that the stakeholder mapping has required significant research, a lot of engagement activities, and a lot of use of referral from stakeholders to others to be able to identify the key people in the country. And last, because of this, it has required significant more time than initially planned because of factors related to, for example, the bureaucracy around having to contact the stakeholders and engaging them. So as mentioned at the beginning, this is an ongoing country assessment, so we are working hard to finalize it as soon as possible and to have the report to be able to facilitate the decision-making of the country to continue to increase and enhance their assistive technology sector. So I'm happy to answer any questions in the chat box, and I hand it over to you, Luis. Thank you.
Thank you very much for that, Maria. And I think what's really interesting there, and I think you really showcased it in the screen back in the graph there, visible on the screen with the various stakeholders and how they interconnect, is what you mentioned there about fragmentation. I think that's something that comes across quite clearly across quite a lot of countries and across the country capacity assessments in general. And that's the complication of all the different elements and all the different stakeholders involved in these processes, and actually the difference it can make with these stakeholders linking up and working together more thoroughly. And also really interesting just to hear about Bolivia, particularly at the very earlier stages of putting together the country capacity assessment. So I'll now hand across to our colleague Maggie from TRI, who will introduce some of the wider team have been working on some of the country capacity assessments across Africa.
Great, thank you, Louise. As previously mentioned, CHI has supported governments in 7 African countries, which is Ethiopia, Liberia, Malawi, Nigeria, Rwanda, Sierra Leone, and Uganda, as well as Indonesia, to carry out country capacity assessments using the ATAC tool. We did this from September 2019 to February 2020. The CCA has been instrumental in raising policymakers' awareness of the need for and the importance of AT, as well as the current challenges and gaps in AT provision in the country. Furthermore, it solidified government commitments to increasing access to AT. Across all the different countries, we really saw some common themes regarding both those gaps, as well as some of the prioritized actions that came out of it, kind of appear across all of the different assessments that were completed. And while they might vary, some of the common themes that we saw included improving data and information systems, setting up leadership and coordination structures, developing national strategies or plans, identifying sustainable financing mechanisms, developing national assistive product lists supported by standards or specifications to guide procurement, and improving human resource capacity and developing comprehensive service delivery guidelines. All different things kind of to fill those gaps and challenges that were identified through the assessment. Today, I'm really excited to introduce 2 of my colleagues that participated and led this work in Ethiopia. Mr. Abbas Hassan from the Medical Service Directorate at the Ministry of Health of Ethiopia. He's the director there, and really is an incredible champion for increasing access to assistive technology in Ethiopia, as well as Eshetu Bekele, who's a member of the Chai Ethiopia team. And they're going to speak about the CCA process and the momentum that it's created in Ethiopia for improving access to medical rehabilitation in AT in the country. So with that, I turn it over to Eshetu and Abbas.
Okay, thank you, Maggie, and thank you, everyone. First of all, I would like to appreciate, the organizer of this session, so that we can present our work in this platform. I'm going to present, I am also excited to present, the 1 year work of Chai with Ministry of Health of Ethiopia, because we started the assessment and work back to 1 year. So as you can see from the, from the slide, the planning phase, there was a training on the assistive technology capacity tool from WHO tool, but since it is, since it is organized, since it is, developed for a wider country, it will not, it should be context, it should be modified. So what we did after we take the orientation from WHO peoples, we tried to customize the tool to fit the context of Ethiopia. For example, to state some of the context, the address and the administrative layers of the questionnaire, which was in the questionnaire was not fit for us. So including that one, and also there were some of the points which should be modified. So we modified the tool in collaboration with the Ministry of Health. So that especially, the formation of the National Technical Working Group, stakeholder working in assistive technology related and rehabilitation service were established by Ministry of Health to state, some of the members of this National Technical Working Groups, ICRC Ethiopia, Cheshire Service Ethiopia, and also St. Paul Millennium and Medical College were members of this National Technical Working Groups. So after that, we, on the assessment phase, we tried to train people's, enumerators on the tool, and we collected data, both qualitative and quantitative data. Once we have collected that one, there was, analysis of the report, and we presented that one for stakeholders. So stakeholders working in assistive technology in Ethiopia, I can say all of them were represented on that stakeholder workshop. So we presented, the findings of the assessment for them. So a good, comments or supplement from stakeholders were also provided. So we accommodated that one, and we finalized the report. So maybe next slide. So here I am going to present, the key finding from the assessment. There were no, any national or lower administrative level data capturing mechanism or reporting mechanism in place for assistive technology services in Ethiopia. Even there is no single assistive technology indicator included in national HMIS. This is, a big finding in line with data related assessment we conducted. The other one was in line with the stakeholder. There is, there is no any robust mechanism for coordination and networking among stakeholder working on Ethiopia. There are a lot of stakeholders working here and there, but there was no any mechanism to coordinate that one. The other major finding we found is that, Ethiopia is currently, having, piloting and exercising the community-based health insurance system and social health insurance schemes. mechanism, but assistive technology was not included in this financing system. So this was also one of the finding we got from the assessment. The in line with the product and procurement system of the assessment we did, what 80 products were not included in the national essential medical equipment or device list. As you may expect, any country or Ethiopia to procure and or to import any devices or products, that product or device should be listed in the national essential medical lists, but assistive technology products were not there. The other one was the regulatory body, which control the standard and the product specification. Does not have any standard or specification for any of the 80 products. So the current procurement of 80 products was majority of done by non-governmental organization working in assistive technology in a more scattered way. So the government share on procurement for 80 products is very minimal. In line with the human resource aspect of the assessment, there was no any national data management system that capture the human resource data for 80. Both educational and career structure needs improvement, to motivate and keep professional working on 80. These were, some of the findings from the assessment. The other was, except for hearing impairment and the physical rehabilitation service, there was no any formal guide or national policy. So this was also one of the findings from our assessment. Maybe next slide. So after we did the assessment, there was based on the stakeholder meeting, Minister of Health, after we submit the finding from the assessment, Minister of Health try to categorize gaps which should be solved by short term, mid term, and long term. I hope that Mr. Abbas will also supplement and will adhere what I'm going to tell you now when I give him a chance. So in December 2019, the MOH established, as I said previously, a national working group was established. This national working group was ultimately given responsibility to follow the implementation of the gaps identified by country capacity assessment. So based on that, in a short term, we identified with the national technical group, we identified activity to be done, and in the midterm and in the longer term. So, for example, in the short term, we have started and we finalized developing on assistive product list. As I said previously, assistive product list were not included in essential medical and equipment list in Ethiopia. So with the national working group and with ministry, we developed assistive product lists. To start with, we take the WHO 50 priority list for least and middle income countries, and we adopted that one. Finally, we come up with 41 assistive product lists. We leave 10 of them. The criteria to leave is that some of the product is not based, maybe because of the technology, maybe because of their cost, or maybe because of the types of disability to be served. We omitted 10 of them, and we included even a new one based on the discussion we had. So currently, Ethiopia developed assistive product list, a 41 list of assistive product list. After we developed that one, we started developing a product specification for this product list, so that to smooth and to solve any specification and regulatory related services. So we developed a product specification. Also in this development of product specification, we gather expertise from different categories, from people with disability, organization from people with disability were part of them, the national working group team, biomedical engineers, because this is a product, so it needs some technical specification for some of, but almost I can say for all of products. So we bring all these peoples and we come up with this one. So currently, our next step is that ministry is now developing a strategy and operational plan, a 1-year operational plan and a 5-year strategic plan, which will be aligned with the HACCP2 of the country. So currently we are in HACCP2. The other one is, strengthening partnership. Currently, we are working with St. Paul Millennium Medical College. So we are partnering with that one, and we are working closely with them. Improving data. There is some started data from the ICRC. So we are trying to adopt and to make it a national data management system for AT service. So we are working that one, and maybe before I give a chance for Abbas, I want to borrow one of his word, working in in CCA, in country capacity assessment on AT. He said in one of our meetings, this is an eye opener for Ethiopia, because even though the task were done by here and there, it was not organized, and it was not in a systematized way. But the tool helped us, to focus where and when. So after saying this one, maybe I will I will give Abbas to reflect some of the slide should be back. Yeah. Abbas, maybe.
Okay. Thank you, Shato. Unfortunately, my headset is not working, so I'm using my laptop. So first of all, I would like to thank you for Chai Global team for organizing this meeting. I hope most of the things that we have accomplished in the previous 1 year as already presented by Shatu. I hope I can add some points on his presentation. So as already Shatu mentioned previously, we didn't have any evidence on the national assistive technology capacity. So this national capacity assessment has helped Ethiopia to know where is a gap on the provision of the assistive technology products at national level. So as previously mentioned, we have assessed the leadership and the governance, the service provision, the human resource development, the financial support for AT provision, and also the information management system at national level. So based on the finding, we had so many gaps. Based on these gaps, we have already developed some interventions to improve national assistive technology access and quality within 5 years. Actually, now we are under development of the or under endorsement of the National Health Sector Transformation Plan. So as a ministry, we have tried to include the assistive technology and rehabilitation service of the national strategic plan, 5-year strategic plan. So that's based on this plan and also based on the finding of the national capacity assessment, the major gaps were on leadership and governance. So to improve the leadership and governance part, we have already established a team at the national level, as already mentioned, and also we have prepared the national rehabilitation and assistive technology management guideline. I hope it will improve all the operational system of the assistive technology product, accessibility and quality. And also now we have already prepared an assistive technology list, which was the most challenging part to procure and supply the assistive technology product at the national level. Previously, we didn't have any national list, so the National Pharmaceutical Supply Agency was most difficult to procure and to forecast the most important assistive technologies. So now we try to incorporate the assistive technologies as part of the national procurement or supply chain product lists. In the third part, previously there was no any impact. We had some procurement and forecasting system, especially with the support of ICRC, but previously we didn't have any system to identify the needs of the physical rehabilitation centers and other health facilities, especially hospitals, those who are providing assistive technology or rehabilitation service in general. So in this year, some of the hospitals try to forecast and align the assistive product as part of their procurement list. In the third part, concerning the human resource, previously we had a curriculum just for diploma, advanced diploma level. Now, with the support of the Human Resource Development Directorate in the ministry, now we are redesigning the curriculum for upgrading the OT P&O, sorry, orthotics and prosthetics professionals. Previously we had only in diploma. Now we are trying to teach degree and degree in orthotics and prosthetics profession. So we are under development of that curriculum, and also we are trying to incorporate the career structure or the career development program in the orthotics and prosthetics service. In the fifth part, previously there was a huge gap in budgeting or allocating budget for the rehabilitation centers and assistive products. So now we are discussing with the regional health boards and regional administrators to improve their budget allocation for procuring and recruiting human resources for the rehabilitation centers who are providing
we're just losing your
technology. So there is.
Sorry, Mr. Abbas, we're just losing your connection a little bit there. So if you maybe just want to do a quick run at final summary, and then we'll move on to the next panelist.
Yeah, okay, so I'm going to finish. So concerning the information management system, in fact, we had a problem with the reporting and also other monitoring and evaluation programs. Product provision in general in rehabilitation service management. So we have tried to develop the national Excel-based reporting format for the physical rehabilitation centers to collect the reports from the facilities and to analyze and utilize that data for decision making. So as a national, we are trying to incorporate key indicators as part of the national health sector transformation plan, monitoring indicators. So in the next time, we will revise the national health information management system. In that system, we'll try to incorporate some of the assistive technology measuring indicators as part of the national health information management system. Thank you so much.
Thank you so much for that. It's really interesting to
I hope
hear.
I tried in Ethiopia in the last 1 year. Thank you so much.
Thank you so much. That was absolutely fascinating to hear a bit more in depth around what's been happening in Ethiopia. And I think some of the key elements that came through that was the value of being able to customize the tool, about the stakeholders and the importance and the involvement through workshops, about the importance of data. And that seems to be something that's come across quite a lot on the questions we're receiving as well, about how countries begin when they have no data and how they can begin that process to I guess kind of unite some of these areas, but also about some of the procurement challenges you mentioned. And it's brilliant to hear how this has kind of kickstarted so many other activities in Ethiopia and all the work that you're doing. So that's excellent. I'll now hand across to Julian, who's just going to introduce himself and tell us a little bit more about informal markets.
Hello, thanks everyone. I'm very happy to be here. My name is Julian Walker. I'm from the Development Planning Unit at University College London. And I'm just going to talk quickly about two parallel studies we did on informal markets for assistive technologies. So these two studies were in parallel to the main Ccas that you've just been hearing about. And one was in Indonesia and the other was in Sierra Leone. And the purpose is to look at informal markets for assistive technologies, by which we meant where people were accessing their assistive technologies through businesses or markets or institutions which are not regulated as businesses or AT providers. So an example you can see in the photo here is Esther, one of our research participants from Freetown in Sierra Leone, who is one of the leaders of a community of people who've had polio, who are mainly wheelchair users, and almost all of them have accessed their wheelchairs from the second-hand market in the city. So if we can move to the next slide. So one of the main findings we had from the two studies, using the RATA tool, the Rapid Assistive Technology Appraisal tool that Emma previously talked about, was that actually informal markets for people in low-income communities was the primary way in which they were accessing assistive technologies. So we did a survey in 2 low-income urban settlements in each city, so 4 altogether, 2 in the city of Banjarmasin in Indonesia, and 2 in Freetown in Sierra Leone, with about 4,000 respondents altogether. And they revealed a high access to AT through informal markets. So actually, if you look at the 2 graphics, the dark blue color is access to AT through informal markets as compared to, for example, government programs or NGOs or formal private businesses. So in the respondents in Indonesia, this was 65% of the ATs were accessed through informal markets, and in Sierra Leone around 30%. Just to be clear, this wasn't the same for all, and actually the majority of these were spectacles, so other ones were less likely, for example, hearing aids. It's also worth stressing that formal provision and informal markets are strongly linked. So for example, in Sierra Leone, even the National Rehabilitation Center, which is a formal Ministry of Health institution, were accessing some of their AT through the informal second-hand markets. Whereas, for example, in Indonesia, some of the informal providers, for example, opticians, would work in a formal optician's practice, but also work informally in the side. So there are linkages between the two markets. We can move to the next slide. So thinking about this, thinking about informal markets as largely unregulated AT providers, I think our normal instinct would be to see informal markets as a problem. But in fact, our research showed that they had a number of weaknesses, but also a number of strengths, which were quite important, particularly for AT users. So the key strength we can see is accessibility, particularly for people on low incomes. Actually, what we see is this is how many poor people are able to get access to AT at low costs. But another thing that people stress was speed. So actually often to get AT through the formal providers, through, for example, the health system, is often a very long process, particularly for people who have to get this in a subsidized way. And getting them through informal markets makes it much faster. We often saw many examples of customization. So actually through informal markets, people are able to customize and adapt their AT to their own specific needs in ways which aren't possible through the formal providers. Another interesting strength is that many of the informal AT providers we looked at are led by disabled people. So actually they're able to bring in their own inputs and knowledge of AT and also create employment for disabled people, which is important. And finally, linked to that, we often saw the informal providers as being a space for innovation. So in the photo, you can see two of our respondents who are both disabled people in Indonesia, where they've adapted a motorbike as a tricycle. And actually we saw a lot of this happening. It was very important for AT users with mobility issues in Indonesia that they were able to adapt motorbikes in innovative ways which aren't available through formal providers, either of AT or of motorbikes. On the other hand, we recognize there were some weaknesses for informal markets for AT. So one issue, of course, is that there are no product standards and rarely medical assessment when ATs are being prescribed or provided, which means that some of these ATs run the risk of being inappropriate or dangerous. And obviously there's less accountability from providers because they're not formally registered or regulated. So if an AT is not working or faulty, it's very hard for people to get comeback. And I think the other weakness that was clear is a lot of these informal providers can't deliver effectively more complex and technological assistive products. So for example, hearing aids in Indonesia, we saw some provision of, for example, amplifiers, but they didn't work well, and actually they could be damaging to the health of users. So if we can move to the next slide. So thinking about the implications of the study, what we could see is actually that in many cases, and particularly for low-income people, informal markets are the main providers of assistive products. So thinking about that, the question that these studies raised is how can the benefits of informal AT provision in supplying otherwise underserved populations and also in terms of innovation be promoted at the same time as protecting AT users from unsafe products and services? So we come up in the report with a number of recommendations for further thought around, firstly, regulation and disincentives to the formal sector. So actually things that push people into informal provision. Secondly, information resources for AT users about good product standards and what they should look at when they're accessing AT through these informal markets, but also information about how they can access things through informal markets. And finally, support to informal enterprises who are producing assistive technologies in terms of improving quality, meeting product standards, and scaling up and increasingly formalizing themselves. So this graphic on the right, which I don't expect you to look at because it's much too small, is making the point that actually, if you look at the range of different AT informal providers, actually, they're all regulated to some extent by the state. And one of the things that we're thinking about in terms of support to informal providers is how to extend regulations which are good for AT users. So for example, around regulating quality and product standards, rather than emphasizing regulation of these informal markets, which are around, for example, getting more tax revenue. So the kind of extension of regulation which will actually be good for AT users. So that's all I have to say. That there's much more in the reports, and if you're interested in looking to this in further detail, the reports are available on the GDI Hub website and also on the WHO Gate portal. Thanks very much.
Thank you, Julian. And I think what's really fascinating there, I think you've really highlighted what the importance of informal markets and providers to the AT picture across these countries, but also that the focus on some of those challenges around the accountability, standards and quality. So I think it's a really fascinating area and really interesting to hear that alongside some of the other examples we've heard today as well. So we're just going to move on to a bit of a discussion. I can see we've already had lots and lots of questions come through the Q&A box as well. So thank you so much for all of those. And I know some of our panelists have been answering them directly. So hopefully you've seen some of those responses. But just as a starting point, I just thought it would be really helpful just to have a quick think about what are some of the key learnings and trends across the CCAs. And I think some of them have come up through the presentations and the conversations we've had today. But I just wanted to briefly introduce you to Luke, who should be one of the panelists on the call as well, who was put together the report that was circulated prior to the session was circulated again afterwards, just to look at some of those key trends that have been identified through the CCA process that obviously is still ongoing as well. So Luke, maybe if you could just say a few words about what would you see some of those kind of key learnings and trends are?
Sure, yeah. So I just want to make sure my video, can everybody hear me?
Yeah, we can hear you and see you.
Great. So I think in the interest of time, a lot of things that the other folks have covered, and so I just want to thank everybody for doing that. I think there were a couple of things that I wanted to highlight that maybe came up but weren't quite emphasized as much in the discussion so far. One, I think, was just the importance of the Ccas tool as a way to inform policy. And so something that I think a couple of the panelists have talked about already is just that there's a real lack of evidence base for policymaking in a lot of these countries. And in particular, when you're engaging with policymakers who aren't automatically familiar with assistive technology. So folks maybe in the Ministry of Finance or in the Ministry of Health, but in parts of it that are not working on disability or assistive technology, ministries of education, that kind of thing. Having, like in many cases, or in many of the countries where this has been conducted so far, the Ccas is the first really systematic, kind of tested, thoughtfully developed national level study that's been done certainly in recent memory around AT. And so it's really critical, and a number, in the discussions that I had with folks in the interviews that I did for the study that Louise mentioned was, just the importance of having that kind of really firm evidence basis, not as that it's the be all and end all, and not that further investigation isn't necessary, but just to have something to build off of is really critical. And that was something that came up in a lot of different places. I think a lot of folks have talked about the fragmentation already. I think the other thing about the CCAs, and this isn't just another trend that came up, is the usefulness of the assessment process itself in improving coordination among all sorts of different actors. So like within the government, for example, in a lot of different countries, people talked about how there's a lot of work going on, lots of different NGOs and DPOs and older people's organizations and government ministries for this, labor and education and of course ministries of health, may all be doing things related to assistive technology, but just very often the right hand doesn't know what the left hand is doing. And so that's something that just again, like about the process of doing the CCA it kind of created that almost an excuse to bring all of these disparate actors together and realize, oh gosh, we're really doing a lot more than we thought in many cases. But we just need to do a better job of coordinating. And so that's something that the colleagues from Ethiopia talked about, is that the CCA has kind of formed the basis for a working group. And that was something that was seen in I think all of the countries where this has happened so far. The working group that was created to do the assessment has kind of persisted beyond the process itself. So that's just another thing that I think was worth pointing out. And oh yeah, just something that came up in the study that I meant to mention in that first point I made. In terms of that kind of evidence base, there was one interview I talked to who mentioned that basically the tool created a kind of wow moment when they were going over the findings. They had a stakeholder workshop in this country, and looking at the kind of confronting the evidence for the gaps in AT in this country. The guy described it as a wow moment for everybody. It was really galvanizing. And I think that's just a cool and important thing to point out. I guess those are the three main points I wanted to bring up, and maybe just again in the interest of time, I'll cut it off there. But as Louise said, the report's published on the AT 2030 website if anybody's interested to hear more. Thanks.
Excellent. Thank you, Luke, and just really helpful just to get that slightly bigger picture as well on the overall findings of the report. We've had a question come in around what is the relevance of the country capacity assessment and the tools that have been created from it in terms of high income countries. So I think, Emma, we'll come to you on that, just to, I guess, get a bit of an understanding of the tools themselves and how they might best be used, and if there is a relevance there for high income countries.
Thanks, Louise. Yes, actually, that came from Chapel, who's in our team, and I think was putting that question out there. You know, are high-income countries interested in the tool? Because we have absolutely developed it as a global tool. It doesn't have a specific focus for less resource settings. I believe that some stakeholders in the UK might have started talking about using it, but we'd be very interested to hear from people on the call as to whether they think other high-income countries could be interested, or whether it could be useful. Yeah.
Brilliant. And it might also be useful just to hear a bit about the tools and how they can be used and how people can access them should they want to find out a bit more.
Yes, sure. Yes. So we've put the tool and supporting documents and also a lot of the other assessments and other background information inside a portal, which will be accessed. People will need to register and describe why they want to access the tool, because we want to keep a little bit of control over it so that we can facilitate in-country assessments, and particularly facilitate assessments that are done in collaboration with governments. So the link, we can post the link to the portal in the chat, and there's more information about that on the homepage of the portal and also on the WHO website. So we're not trying to sort of guard it or be too over controlling, but more so that we can really play a facilitatory role. I think going back to the fragmentation, we all know that in some especially bigger countries, you could easily end up with a scenario with various different groups could decide to implement the tool without even knowing that each other were doing it. So we'd like to sort of facilitate connections and collaboration in countries and avoid that scenario.
Fantastic. And I think what comes across strongly, and I think has also really been indicated throughout all the different presentations today, is that mutual learning, and actually how interesting it's been to look at this process across different countries and be able to do that moving forward with new countries that come on board and start to use these tools and replicate what's been happening in the country capacity assessments further. So we're just going to do one final question because we're quite short on time now. So I think what we're going to do is there've been quite a few questions around the data side of things, and for countries that are starting out that maybe there's very limited data and limited appetite for that. So I maybe just wanted to quickly come across to Maggie and just hear just maybe in a couple of sentences really, just a short overview on what would be your advice in terms of some of those data challenges and how you found was the best way to go about resolving those when you were beginning the Ccas across Africa.
Absolutely. I think when thinking about these data challenges, I think both Maria and Eshatu spoke to this really well, that it really comes down to identifying those stakeholders within the country and starting to really kind of work together to understand what is in existence in the country. So I think many of the countries that carried this out used the snowballing method. I think that Maria touched on a little bit as well of really identifying, you know, who are those core partners that are easily identifiable, and then who might be working through this fragmented landscape in those other areas, and really trying to build that coalition, which we saw in many of the countries turn into these technical working groups that bring together both the ministry as well as private sector and NGO partners that are working in the country to really begin to identify and work to see what that data is. And I think what we saw in a variety of countries is the lack of data is a finding in and of itself. I think Luke spoke to this really nicely of how that lack of data and those aha moments helped move this forward. But I think when you see that lack of data, there are ways to really look across that stakeholder landscape and start to piece together what are the different pieces that individuals have. And then I think also speaking to kind of that overarching toolkit that Emma talked about, that hopefully, over the next few years, that there's opportunities to build, to fill in that dearth of data with things like the RATA and the rapid AT assessment and things as such.
Excellent, thank you. Great summary of a big question right at the end there. So we're coming towards 2 o'clock now, so I'm just going to hand back to Vicky, who introduced the session at the very beginning, just to hear any final reflections before we begin to wrap up.
Thanks so much, Louise, and it's been a real pleasure to listen to everyone's comments and contributions, and especially thank you to our colleagues from Ethiopia for joining and telling us about their experience. For me, this has been a real pleasure project as part of AT 2030 because it's shown the real value of bringing together partners from different perspectives. I think when we came into the project, we had a tool from WHO and they have been absolutely brilliant in kind of driving that forward, already been trialled in some countries and supporting this process and continuing to drive forward and coordinate, as Emma said. It's vital that this is coordinated, of course, because it would be really detrimental to the aim of the tool to have more than one operation in one country, so it makes perfect sense. You can catch the kind of wider documents on the AT 2030 website in time, but do go to the WHO portal to find out the details of implementation if you're interested in your country. I think CHAI have taken the document that we started with and built it through their expertise and skills and implementation in a way that has enhanced what we now have as a tool, and I can't thank Julian and his team enough for raising the significant issues around access to informal markets and the way in which many poor people do access assistive technology being a reality. Because of course, planning for those scenarios in our countries where every decision directors of health make is determined by the data available to them and actually scarce choices of where to spend money. It's really important that we can reflect on those aspects as well, and I think through Julian's work and the response from the wider team, we've seen the tool now take better account of informal markets and also more account of user involvement in the process as well, so something else that we've learned, as Luke mentioned. So for me, it's been a real joy. Thanks again to UK Aid for funding this piece of work. I think it develops and has developed a public good which will be available in this space. And I think, as Maggie said, the lack of data was very much a stark data point in itself. And so we find ourselves in a slightly better place on access to assistive technology as a result of this piece of work. So thank you, everyone.
Thank you very much, Vicky. So that brings us towards the end of the session for today. I've just put a slide here on the screen with a couple of links, which we will share around after the session. I think have also been shared in the chat as well. As we mentioned towards the beginning, there'll be a transcript and also a recording available, which we'll email to you all as soon as that's ready. So do have a look on some of those sites just to find out some of the more detailed information that has been mentioned today. Looking forward, our next Disability Innovation Live session will take place on the 17th of December, where we'll be looking at race, disability and innovation. So please do join us then. We'll also send you some more information about that up and coming session. So really that's all everything for today. So a huge thank you to everybody from all over the world that have joined us. It's been brilliant to have you all involved. As I said, we'll be providing a little bit more information, but thank you so much as well to all the panelists that have been able to join us today. And a special thank you to the BSL interpreters and also the captioner today for adding the accessibility elements as well. So just a bit of an overview. So the country capacity assessment is a UK aid funded project as part of the GDI Hub's AT 2030 programme. Thank you so much for joining and we'll see you again soon. Cheers, bye.